gaining for the last 3 years is that people are getting to know each other, getting comfortable with each other, and I encourage you to come early and stay late, because while in this room we bring together best practices presentations and we inspire through those who are very top performers, and now I think I can settle my voice down so I don't blow your eardrums out. What the real value of the Right Care Initiative is all those relationships that develop so that you can figure out your own pilot projects, your own ways to organize to implement the best practices. We have a wonderful presenter today who I will allow Dr. Arevalo to introduce, but first, why don't we go around the room and introduce ourselves to each other. Because we have a large crowd today and we're running late, please just your name and organization, no announcements.
Is it on? Yes. Okay. Susan Ivey, UC Berkeley School of Public Health and family physician practicing in Berkeley.
Jessica Nunez de Ibarra, California Department of Public Health.
Yvette Kroppel, Western Health Advantage.
Jennifer Berg, Department of Healthcare Services. Marishina Pai, Department of Healthcare Services.
Louder, please.
Vivian Cedro, Department of Healthcare Services.
Hi, I'm Annalie Amarnath with Department of Healthcare Services.
And Maureen Farrell, Department of Healthcare Services.
Jennifer Whitekowski, Health Services Advisory Group.
Jason White, Public Health. Jason White, Public Health. Dennis Littlefield, Sierra Hill Foundation.
Liz Helms, California Chronic Care Coalition.
Joe Warbling, California Health Collaborative.
Sergio Garciola, UC Davis.
Don Hubbard, Western Health Advantage.
Kristen Robinson, Kaiser.
Mike McCabe, Sutherland Health Solution.
Ralph Goldinger, Sutter Independent Physicians.
Jacqueline Weiss, Genentech.
I'm Steve Jackson with Genentech.
Chris Gunther, also with Genentech.
Sue Fuentes with University of San Francisco. Heidi Wren, Sutter Health.
Sophia Clark, California North State University and Sutter Health.
Laura Blonsky, Sutter Health.
Jim Ellsworth, Capital Health Network.
Don Forster, Switch Healthcare and Nurse Save International.
Alyssa Zina, Sutter Health. Jocelyn York, Sutter Health.
Leonard Fry, LWF Home Care.
Jerry Jeffy, California Chronic Care Coalition.
Shelley Bolton, Novo Nordisk.
David Matsumura, Novo Nordisk.
Warren Barnes, UC Berkeley School of Public Health, Grace Presbyterian Church in Sacramento.
Doug Robertson, Hill Physicians Medical Group.
Dan Tuberty, Barringer, Vermont.
Sharon Chandler, Yes to College Education and Health Resources, Inc.
Tony Holly, Perry Educational Consultant.
Gordon Wong from Department of Healthcare Services.
Amy Tomajiba from University of San Francisco.
Shao Lynch, UCSF School of Pharmacy. Rebecca Strauss, Pharmacy.
Roy Schutzengle, Health Services.
Good afternoon. Thank you for being here today, and we got a good crowd. I'm Jose Alberto Arevalo. I'm with Sutter Independent Physicians, and I'm also one of the co-directors along with Dr. Erdl for Right Care, and we wanted to basically, again, remind you that we have these cards that we put together for basically an algorithm around caring for patients with hypertension. This is our first major product in Right Care, and it's taken off actually. We've gotten a lot of positive response. I know, and my boss is here, Ron Goldinger, and we have our PCP regional meetings that we just had last week. We have half of our PCPs who come to our meetings, and we provided all of them, adult medicine doctors, a copy of the card, and already I've gotten several of the docs who want these cards for their colleagues and for their mid-level providers. So we do have some available. We have a limited supply. We don't want to take them all here. They're right here in the box if anyone would like some. We do have an agreement with the Department of Health Services and Medi-Cal to print some more, about 1,000, but that's certainly forthcoming. Do you know when that's coming, Hattie?
Jennifer Byrne, could you just mention the restrictions on those cards and the timing?
Sure, certainly. Those cards have to go directly to providers who see at least a portion of their patients are Medi-Cal members, and we hope to have them by the September meeting.
Thank you.
Great.
Really appreciate your partnership, and rather than people just coming and taking these cards out of the box, please work through Amanda so that we check them out by medical group, so we make sure that every medical group that has requested them gets the right amount. So we have to prioritize those that already put in orders.
So again, this is our first major project in terms of a product that Right Care would like to put out there. We'd also like your feedback around these because it's going to be very important. Now, we don't have a feedback tool, but we'd like your individual feedback as to what you think of the cards and how it's working for you. Eventually, I think we'd like to do a formal tool to see if we can document the use of these tools. And also, as you may know, CAPG is taking on looking at this tool and circulating around CAPG in the other areas. So we are very excited about this. So I'm going to turn it over now. Oh, yes.
Have you thought about doing an app for that, so that people could have it right on their cell phone?
We wouldn't be the group that would do an app, but we'd be happy to, relay that information if it becomes available. One thing that we want to do is have each medical group, and today it's Sutter talking about what they're doing and Mercy talking about what they're doing, talk about how they're using the cards and other things they're doing in this portion of the agenda that is the hypertension update that will happen at the beginning of each meeting. So you'll have to come and schedule your time on the agenda for your hypertension update. Back to you, Dr. Revelo.
Okay, Jerry, was that okay with? Yeah, we can work with you if you're interested in
well, there's some health care organizations. Their approach, I have a feeling they might be interested in doing it.
Yeah, I agree with that. And carrying the card is one thing, but my son is a junior resident. He carries a smart device. He doesn't carry anything. Well, he carries a stethoscope.
Could you make it accessible on the Right Care Initiative best practices page?
This is accessible, isn't it, Amanda? Mm-hmm. Yeah.
It's accessible online.
Yeah, there's a link on the rightcare.berkeley.edu homepage. You can either click on that icon, or it's under our tools and links page. There's a header. It also has some other resources that we found in the community, and also at the top of the page you'll find information about the hypertension guidelines.
So it is available for the healthcare organizations to print as many as you would like. The formatting has all been done. If you have any trouble with that, just email us, Amanda Liu at berkeley.edu is our graphics wizard, among many other wonderful roles she plays.
And again, the idea is this to go out to as many providers who take care of patients with hypertension as possible. It is based on Joint National Committee 8, and there are some slight modifications of which it's annotated here so you see, but it's really to get it in the hands of as many doctors as possible so that as many patients as possible get the right care. So you can plagiarize it as much as you'd like, as long as you give credit to the right kid. And by the way, I need to thank Susan Ivy for doing most of the great work in putting this together. So I'm going to turn it over now to Mary Firmison, who's going to introduce our next speaker.
One more, Dr. Erdl is going to talk about what they're doing at Mercy.
So just a little bit of we're going through the process to adopt some of the planks that measure pressure down, including plank 1, which is accurate measurement of blood pressure. So, and part of, nope. Okay, sorry. Part of doing that is to automate all the blood pressure cuffs in all of the clinics for the MAs and have those electronically linked to the EMR so that there's no manual data entry that has to happen. So there's going to be a process to do that. About half of the blood pressure cuffs in the group are automated, and there's many different models of many different kinds. But the one that we need to adopt is specific because it will adapt to all scripts and be able to be linked. The other is that we're adopting, I think it's plank number 5, which is that we're going to ensure that every touch of the patient, every visit, no matter what specialty, has a blood pressure measurement done. And we've already, and part of that is an algorithm for the specialist to say, if they don't feel comfortable in addressing the blood pressure, how do they contact the primary care physician, and at what level does it become really a medical emergency, where that call needs to be made personally, physician to physician or provider to provider. So it's those things that we're going down the road. I suspect that this will continuously evolve through the fall of this year, and that by early next year we'll probably be doing all of this 100% of the time. And we think that part of our failure, if you look at measure of pressure down, is that if you don't take a blood pressure, that's considered a failure. That is, they're not in control. 14% of our visits do not have blood pressure measurements done. It's mainly specialist office of various types. So we need to do that, and it will change their workflow. There's going to be pushback from some of the specialists to do it. We need to figure out how to do it efficiently for them. So that's what we're thinking about, and that's what we're doing.
So Mary's just going to do a brief introduction of her colleague Jennifer Wykowski. Great.
Hi. So let me introduce my teammate here, Jennifer Wykowski, who is a gerontologist, and she is our state program director. And what that means is she's overseeing all of the work that we're doing here in California as part of our QIO contract. And today she's going to speak especially on the diabetes self-management education program that we're working on.
Excellent. This is working great. Hi, everybody. So I'm Jennifer. I've been with the QIO since 2008, and I've really focused on improving nursing home quality and reducing readmissions, which has been very popular since about 2011, right? And I actually just got on the diabetes task to help people get education to manage their diabetes. I just got on this program about 3 weeks ago. Our QIO is very new to spreading disease self-management or diabetes self-management programs. QIOs, Medicare has charged all of us to work with our states to help bring 6-week diabetes self-management workshops to communities. So we have some resources to do that. So in just a few minutes that I have up here, I wanted to be really direct because I do have a calling or a question to see who's interested in joining this initiative. So really quickly, we know that a lot of people are diagnosed with diabetes, and I'm especially very interested in this because my daughter's best friend just got diagnosed at 7 years old. My parents just got the message from their physician that they're borderline diabetes. We know that this is going to keep growing, that people are going to need education out there. And so that's why QIOs are charged to do this. We are specifically interested in bringing education to these populations up here on the screen. African Americans, Hispanic Latino, American Indians, Asian Pacific Islander, and people who are living in rural areas who don't have access to the education they need. Am I breaking in and out here?
You're doing great.
You can hear okay? Okay, great. Excellent. So we know diabetes education is a solution because when you do get that diagnosis or pre-diabetic information, it's a lot to handle. It's overwhelming. And so we know that education, providing opportunities for people to get together in a support group kind of structure is the way to go from the evidence. So Affordable Care Act definitely wants to see these programs spread, and that's what we're here to do, to help people take an active role in their diabetes. The ultimate outcomes that we want to see is obviously education opportunities, making that available in Sacramento and other communities throughout the state. But we also want to see improved clinical outcomes at the end of the day. And A1C, lipids, blood pressure, and weight control. So as part of this initiative, on some of the patients that are going to go through the class, we're actually going to be looking at their clinical measures to see if there's improvement over time. We also want to decrease lower extremity amputations and improve overall health literacy with diabetes so that people are empowered to be able to talk about their diabetes and to understand some of the big words that their physicians are sharing with them as they progress with their disease. So my question to all of you, something to think about, is that we as a QIO want to team up with organizations that have access to people who need this type of education. Medicare, since this is actually Medicare's funding that is trying to push this out to people, we're really interested in the Medicare population, but other payer sources are very important too. Everybody deserves to have diabetes education. So we're looking at all payer sources. Everybody with diabetes counts, but certainly we're looking to partner with organizations that have an access to the Medicare population and access to people who are pre-diabetic or diagnosed already. So we want to team up with you, but keep in mind this program is not for everybody. This program is best implemented in places where people live, work, play, and worship. So we know churches, senior centers, community rec centers. Sometimes physician offices can be a good opportunity to host one of these classes as well if people have transportation to be able to come to these classes. So we're looking to partner with people, and I ask that following this today, if you contact me, there's my contact information. Love to have a conversation with your organization, with you as an individual. We're looking for people to lead these classes. These are volunteer-led, but also it's best if there's sustainability and training people who are actually delivering these classes as part of a senior center program or something. So come talk to me, and I'd love to see if there's a good opportunity to spread this. Thanks.
So remember everyone, this is a free resource available to all of the delivery systems. Jennifer will be here after the meeting to talk with you about how you can partner.
Yeah, all free training, free tools, we'll provide that for you. You just have to find a way to implement it. Devil's in the details, right? Thank you.
Thanks, Jennifer. Really appreciate it.
Yeah, thank you, Jennifer. That was great. So I want to, I'm very proud and this is a great opportunity for me to introduce someone who I've known for a long time. And Lindsay and I, Dr. Lindsay, were residents together back just a few years ago at the San Francisco General Hospital, and also Alan Glasroff, her husband, was a resident as well. In the meantime, she's gone on and done some amazing things, and she's going to share with us some of the things that she's now learning, doing and teaching in the Stanford area. But in the meantime, she's done another really great thing, and her daughter just is now taken her place as a resident at San Francisco General. So congratulations, the legacy continues. For those of you who don't know Anne is co-director of Stanford Coordinated Care, which is a capitated program for primary care for Stanford employees and adult dependents with complex chronic health conditions. The care is provided through a partnership between patients and families and their multidisciplinary care team, including physical therapists, behavioral health, nutritional therapy, and clinical pharmacy, and of course primary care. The emphasis is placed on the patient's own goals, care coordination with specialists, and helping patients gain the skills to be healthy and as healthy as possible whatever conditions they might have. She also currently serves as clinical advisory committee for the Pacific Business Group on Health, CMMI support project, intensive care outpatient program, which seeks to enroll 27,000 patients in 3 states by 2015, and that should be a really interesting program. She is a fellow for the California Healthcare Foundation Leadership Program and joined the IHI faculty in October of 2013. Prior to moving to Stanford in 2011, Dr. Lindsay shared a family practice with Alan, her husband, in rural Northern California for 28 years. And they did some amazing things while they were there as well. During this time, she served as county health officer for 18 years and was active in the leadership of the California Conference of Local Health Officers in Sacramento. In 2006, she received the Pleshner Award from the California Medical Association as a physician who best exemplified this practice and the ethics of a rural practitioner. So I'm really happy to introduce Anne, who's going to be talking to us about ambulatory intensive care, which is a topic that is going to get more and more notoriety as time goes on. So thank you, Anne.
I'm going to talk about the care of complex patients, and particularly in our setting at Stanford, which is a self-insured setting and everybody. But there are elements of it that are applicable to other populations, and I'll go into that. But I also know that all of you are having trouble recruiting primary care providers, and so there are elements of my talk that are relevant to that, because my opinion is that we can't just create more providers. There's not enough in the pipeline to meet the need. We have to create the conditions that make working in primary care a really fun thing. And so there are some, I'm going to go into teamwork and how we're doing that. I have no, my disclaimer. No financial interest in this. This slide is from the Pacific Business Group on Health. As Jose mentioned, I was faculty, and the program is done, by the way, for a CMMI grant, and I'm going to present some data from that, and there are Sutter and other organizations here participated in that, so it'll be fun to see some of the data. But our program is called Stanford Coordinated Care. Actually, we were brought to Stanford by Arnie Milstein, who many of you know, to do an ambulatory intensive care unit. Caring unit, and our patients hated that name, so they helped us really come up with the idea of coordinated care. The premise, and this fits with what Jennifer was saying, is that Steve Schroeder at UC San Francisco did work on determinants of health and contributors to premature mortality. And so health care is only responsible for 10%. So 40% is behavior and what people do with it, and how you, and particularly in diabetes, it's very easy to diagnose diabetes. Very hard, often, to live with it, or it takes a lot more effort. So in our program, and I think that programs that focus on people with complex chronic conditions, or people who are just not doing well, focus on the behavior and supporting the behavior that allows people to be healthy with their conditions. The notion of this was spearheaded by Arnie Milstein at Boeing and Atlantic City Resorts with the Unite Here union, and they had led just special care. I call it concierge care for people who really need it, and they were able to achieve an 18 to 20% reduction in per capita spending. And there's all kinds of problems with trying to determine that, but I'm not going to get into that now. But they had propensity match controls. And then Alan Glasroff, my husband, was working with the Humboldt Del Norte IPA and partnered with PERS and Pacific Business Group on Health, and Anthem was at ASO, and had a disseminated model. So they didn't work providing primary care directly, but they had a panel of nurses who would provide care support, basically, to people with chronic illnesses, and 25 private practices. So the model, the Pacific Business Group on Health called what Arnie did at Boeing the intensivist model, so actually providing primary care services. And then the Humboldt model is the distributed model, whereas primary care is provided elsewhere, but you layer on some services for people who need them. At Boeing, you know, we looked at the triple aim, or actually I say the quadruple aim of not only cost, but health outcomes, and patient satisfaction, and the fourth part of that is staff satisfaction, which I think is really important. And in primary care, you know, surveys of people in primary care, the thing that's most important to them is not necessarily the dollars and cents, but the capacity to provide good quality care. And so that there were a very good data from Boeing that they were able to achieve those areas, although they did not look at the staff there. From the CMMI program, I'll be presenting data. They did actually, they tried to get 27,000 people enrolled. We were able to get 15,000 enrolled. There are 23 delivery systems, 500 practices in 5 states, and they were able to engage 72% of the patients. These were all Medicare patients who they contacted and offered services. And some of them had the intensivist model. Mostly it was the distributed model where they had nurses or staff, unlicensed staff working with nurses to provide that extra support that people with chronic illnesses need. If you look at patient population, you know, by far the largest number of people don't need much. You know, in fact, and it's all about risk stratification, as we were saying, and they probably, as Kaiser has found out, that online is adequate for most of their needs. As you go on with more chronic illnesses and complex chronic illnesses and high complex social settings, and you really need a higher intensity of intervention. There's, but in terms of opportunities for saving money and making a big difference in health outcomes, the people who are complex have the most opportunity there. So we all have heard a million times that 5% of the population costs 50% of the healthcare dollars, and that goes for every population that I've ever seen analyzed, with Medicaid, Medi-Cal, our population at Stanford, and other health plans. So they're depending on who's in your population, you may have to design a different kind of program, and these are, we've worked with the Center for Healthcare Strategies on listing what are the different kinds of complex population. So pre-complex population is people who have a chronic condition and haven't really, we call them the farm team at Stanford. They're not really, and we try to keep them there, and we don't want to bring them up to the majors and for our clinic. Then there's the complex emergency department of frequent visitors, the ambulatory complex medical patient, homebound complex medical patients, a different type of program. Long-term care patients are also a type of opportunity for improving their experience and their outcomes. The complex rare disease patient, and we actually get a lot of those at Stanford, believe it or not. And the primary care sensitive visit group, and this is really where Jeff Brenner and Camden did a lot of pioneering work in Camden, New Jersey, with people who really didn't present to the hospital and didn't really need to be there. They were there with something that really could have been taken care of in a primary care setting. So how do you find the populations? You know, unfortunately, we use a combination of methods at Stanford. We use the MARA risk diagnosis risk adjuster, and which looks at claims, and it's about, you know, for the top 30%, top 10% of the population is about 30% accurate in determining who has the prospective risk, who's going to have their problems are going to persist, and they're going to be in a high-risk category. And that's the real challenge. It's easier to see who has the concurrent risk, you know, who's having a hard time this year, even though, you know, and there's a lag in claims, you know, so it makes it harder to respond in a timely fashion. But really, if you get people who have a high concurrent and high predictive risk, you really, those are the people who you're really going to perhaps get the most return on investment, and that's who we focus on.
Can you elaborate on that a little bit? What do you mean exactly?
So concurrent risk means in the past, you know, 6 to 12 months, what have your healthcare costs been? Prospective predictive risk or prospective risk is different, all those companies I listed have tools, and many of you use some of them or all of them or different ones that predict based on their past utilization, the diagnoses, are they going to be in the high-risk group in the year that comes? Because that really, there's a whole progression to the mean. A lot of people with complex conditions or some health conditions that cost a lot get better. And they're not the ones that are going to need the services that you're offering them. The Denver Health, and actually there's an article in Health Affairs in August 2015 reporting their outcomes with frequent emergency room visitors. But if this is kind of a busy slide, but if you see that they have an integrated system with hospitals and ambulatory care and in a managed care network, so they have a lot of data, and they followed 100,000 or several 100,000 episodes of care over a number of years. And I'll bring you right down to the people who have in their system who have dominant chronic disease in 3 or more organ systems are tend to lie in the tier 4, which is the persistently high utilizers. So that is actually one of the criteria that we use to refine what we get from the Morrow risk adjuster. What conditions people have, and you can some conditions might go away. Yeah.
Oh, we're getting a feedback, and it's probably that the microphones are turned on.
Yeah.
They're on. Okay.
What do I do?
So if we continue,
Stand back.
would you just have their IT staff work on it?
Although this talk rings true.
We also use a tool
You're welcome.
called Harms 8, which we borrowed from Health Oregon, and and people fill it out online to actually have to qualify for our services at our clinic. And one of the main questions it seems to predict whether somebody's going to persist in having health needs is how do you feel? How have you been feeling the last 3 to 6 months? And if they say fair or poor, they're generally people that we feel we can help and make an impact. And the magic number is if you have 5 or more prescriptions, and if you, and for the Medicare population, you want to know whether they can complete activities of daily living, because that's a predictor of hospitalization for sure. That, and thinking clearly, these are ones that we actually don't use in the Stanford population because they're by and large employed, and but for the Medicare population, those questions are important. Prior utilization, emergency department or hospital admits, and whether you have a support system, and how confident are you that you can handle your health problems. If you're people who aren't confident tend to be high utilizers of services. And somewhere there, it's how many specialists you have, because that's the #1 condition of import. At least 8 people at Stanford have specialitis, and that's a dangerous neighborhood. So it's a specialty land. The focus of our program is to coordinate people's care so that they really get what they need out of it. So Stanford Coordinated Care is, we focus on the ambulatory complex patients or people with rare or unusual conditions. They're all employees and dependents and adult dependents of the Stanford self-insured health plan. And we get paid per member per month, so we don't do any